If you started testosterone therapy and your hair began thinning, nobody misled you exactly, but somebody almost certainly left something out. Because the connection here is not complicated, it is arithmetic. DHT is not something your body produces independently. It is made from testosterone. Your body takes testosterone and converts a portion of it, using an enzyme, into that far more potent hormone. Which means if you raise your testosterone, you are raising the supply of raw material feeding that conversion. That is not a side effect in the strange, unpredictable sense. It is the pathway working exactly as it always has, with more going into it. Now, this does not happen to every man on treatment, and I will explain why in a moment, because that part matters. But stay with me to the end, because number one is the trade-off. Almost nobody has explained to you properly where the obvious way to protect your hair works directly against some of the reasons you went on testosterone in the first place. And before anything else, let me be clear. Nobody stops testosterone therapy because of a video. And there is a specific reason that is more serious than usual, which I will come to. I'm Dr. Alan Brooks. I have spent 35 years as a board-certified dermatologist, focused on hair and scalp, and more than 10,000 patients have sat across my desk. And this is a conversation I have far more often than I did a decade ago, because testosterone therapy has become considerably more common, and a good deal of it is now prescribed through online services where the consultation is brief and the follow-up is thin. Some of those patients had this explained to them thoroughly. Many arrived in my office genuinely surprised, having connected the two things themselves months later, and feeling slightly foolish for not having asked a question nobody invited them to ask. This channel is where I say what I never have time to say in a 15-minute visit. Maybe that is you. You feel better than you have in years. Your energy came back, your mood lifted, you are stronger in the gym, and you would not undo that decision. And now your hairline is moving, or your crown is thinning, and you are caught between two things you want, feeling slightly ridiculous. For even weighing them against each other, you are not being ridiculous. Wanting both is entirely reasonable, and the useful conversation is not whether to want both. It is what is actually adjustable and what is not. So let me show you the pathway, because everything in this video follows from it. Picture your testosterone as a river. Two tributaries branch off that river. The first is the enzyme 5-alpha reductase, which converts a portion of your testosterone into DHT. In men whose follicles carry a genetic sensitivity to DHT, that hormone binds to receptors at the base of the follicle and issues a slow shrinking instruction. So each growth cycle rebuilds the follicle a little smaller until the hair it makes is too fine to count. The second tributary is a different enzyme called aromatase, which converts another portion of your testosterone into estradiol, a form of estrogen, which men need in modest amounts for bone health, mood, libido, and several other things. Now, here is what happens when you raise the level of the main river. Both tributaries rise with it. You went on treatment for the river, for the energy and the strength and the mood. The tributaries came along whether you wanted them or not, and one of them runs directly to your follicles. That is the entire mechanism. And I want to add the reframe that I think matters most here, which several of my patients have found genuinely useful. If your hair responds to this, testosterone therapy did not create a condition you did not have. It revealed and accelerated one that was already written into you. Those follicles were always sensitive. In most cases, you would have lost that hair eventually. What changed is the speed, and speed is negotiable in a way that genetics is not. So let us go through the 5 things, counting down. Number 5 is understanding that the route of administration genuinely matters. And this is one of the more practical things in this video. Testosterone can be delivered by injection, by gel or cream applied to the skin, by patch, or by implanted pellets, and they do not produce the same shape of curve in your bloodstream. A large injection given every 2 or 3 weeks produces a substantial peak in the days afterwards, followed by a long decline before the next one. Gels and creams applied daily, or smaller injections given more frequently, produce a considerably flatter, steadier level. Why does that shape matter for hair? Because conversion into DHT is driven by how much testosterone is available, and a high peak means a period of considerably more raw material entering that pathway than a steady level would provide. So, one of the most straightforward things a prescriber can adjust without reducing your overall dose or the benefit you are getting is the frequency and therefore the flatness of your levels. That is a genuinely useful thing to ask about, and it is the sort of adjustment that is routine on their side of the desk. The mistake is assuming the only lever available is the total dose, when the shape of the curve is a separate lever entirely. Number 4 is that this does not happen to every man, and understanding why tells you something about your own situation. The determining factor is not how much testosterone you have. It is whether your follicles are genetically sensitive to DHT in the first place. 2 men can be on identical regimens with identical blood levels, and one loses hair while the other does not, because one inherited receptors that respond to that signal and the other did not. This is also why the hair at the back of your head is unaffected while the top thins, because those follicles have almost no sensitivity, which is exactly the principle that makes hair transplantation possible. So if you have been on treatment for 2 years and your hair is unchanged, you are very likely not going to have this problem, and you can stop worrying about it. And if your hair is responding, that tells you the sensitivity is there. Which is useful information rather than merely bad news, because it means the ordinary approaches to pattern hair loss apply to you. Now, before the top 3, let me mention something I will come back to properly, because there are 2 things traveling alongside your treatment that almost nobody connects to hair, and one of them has a free resource attached. Number 3 is your estradiol, and this is where I see genuine harm done, usually by people acting on internet advice rather than medical advice. Because some testosterone converts to estrogen, and because men are often uncomfortable with the idea of estrogen, there is a widespread practice of taking medications called aromatase inhibitors to suppress that conversion, sometimes without any medical indication at all. Here is why that concerns me. Men need estradiol. It is not a contaminant. It is involved in bone density, in mood, in libido, and in joint health, and driving it too low produces a genuinely miserable set of symptoms, including aching joints, low mood, poor libido, and, over time, weakened bones. And there is a hair angle too, because estrogen is broadly protective for hair follicles, extending their growing phase, which is precisely why women's hair often thickens during pregnancy and thins after menopause. So a man who suppresses his estradiol aggressively may be removing a protective influence at the same time as increasing the shrinking one. The mistake is treating estrogen as the enemy. Your prescriber should be managing this based on your symptoms and your blood work, not on a forum consensus. Before I give you the top 2, do something for me. Type in the comments what form of testosterone you are on and how often you take it. Injection every 2 weeks, weekly, daily gel, pellets. And tell me your age, and whether you noticed hair changes, and when. I have a suspicion that the pattern between dosing frequency and hair complaints is going to be visible in those answers, and I think it will be useful for everyone reading. Number 2 is the one almost nobody connects, and it is genuinely important. Testosterone therapy raises your hematocrit, meaning the proportion of your blood made up of red cells, and that is monitored precisely because it can rise too far. The standard management for that is to remove blood, either by donating or by a procedure called therapeutic phlebotomy. Now follow that through. Every time blood is removed from your body, iron goes with it. Do that regularly, several times a year, over years, and your iron stores fall. and low iron stores are one of the most common causes of diffuse hair shedding there is. So you may have two entirely separate things happening to your hair at once: the hormonal pathway thinning it in a pattern, and depleted iron reserves causing diffuse shedding on top of that, caused not by the testosterone itself, but by the management of one of its effects. Here is what makes this so easy to miss. The test that reveals your iron reserves is called ferritin, and it is not part of standard testosterone monitoring, which quite reasonably focuses on your testosterone, your estradiol, your hematocrit, and your PSA. Nobody is being careless. It simply is not on that list. And a standard blood count can look entirely normal while your reserves are empty, because your body drains the reserve to protect the working supply. So if you are on treatment, having blood removed periodically, and losing hair, that is a specific and correctable thing worth checking. And on exactly that point, let me give you the practical thing I mentioned. There is a free page called the Blood Worksheet, 10 pages, put together by the written companion guide to this channel. It lists the tests to ask for when you are investigating hair loss, written exactly the way a laboratory orders them, with a line on why each one is there. And it gives you the sentence to say out loud so you are not improvising in a short appointment. It is a separate list from your testosterone monitoring, which your prescriber already handles. And that is rather the point, because those two lists do not overlap, and the hair-relevant one is the one nobody is running for you. It carries the warning signs page in full at the front, because that page should never sit behind a payment. It costs nothing, and there is nothing to buy. You will find it linked in the description below. And now number 1, the trade-off that almost nobody explains properly. The obvious way to protect your hair while staying on testosterone is to add a medication that blocks the conversion into DHT, meaning finasteride or dutasteride. And it can work, and plenty of men do exactly that under proper supervision. But here is what rarely gets said. DHT is not simply a hair villain that your body produces by mistake. It is a potent androgen involved in libido, in erectile function, and in several of the effects men are actually seeking when they go on testosterone therapy in the first place. So you may find yourself in the position of taking one medication to raise your androgens, for how it makes you feel, and a second medication to block the most potent of those androgens to protect your hair, and those two are pulling in opposite directions on some of the same outcomes. That is not an argument against doing it, and for a good number of men the balance works out well. It is an argument for going into it with your eyes open, rather than treating it as a simple add-on, and for paying honest attention to how you feel afterwards, rather than assuming any change is unrelated. Let me tell you about Mark, 53, a patient of mine, who had been on testosterone for about 18 months, felt transformed by it, and was distressed by how quickly his crown had thinned. He had already read about adding finasteride and had half decided. We did 3 things instead of 1. His prescriber moved him from a large injection every 3 weeks to a smaller one weekly, which flattened his levels considerably. We checked his ferritin, which was low, because he had been donating blood twice a year to manage his hematocrit, and nobody had connected it. And we started him on topical minoxidil, which works on blood supply and does not touch his hormones at all. 6 months later, his shedding had settled, and he had not needed to take anything that worked against his treatment. He may still choose to add a DHT blocker one day, and that will be a considered decision rather than a reflex. So here is exactly what to do. But before the plan, let me deal with 3 things that circulate constantly in this area, and that will not help you, because I would rather you spent your effort on the 4 steps that follow than on these. The first is switching to a different ester or brand of testosterone, in the hope that one converts less to DHT. The molecule delivered is the same testosterone, regardless of the ester attached to it. And while the release curve differs, which is exactly the frequency point I made earlier, there is no version that quietly skips the conversion pathway. Adjust the curve, by all means. Do not go looking for a magic formulation. The second is the idea that you can outrun this with topical DHT blockers of the botanical kind, while raising your testosterone substantially. Saw palmetto and similar are worth what they are worth, which I have covered elsewhere, but expecting a plant sterol to counterbalance a pharmaceutical increase in your raw material is not a realistic plan. And the third is the belief that if you simply keep your dose low enough, this cannot happen. Dose matters, but sensitivity matters more, and men on modest replacement doses lose hair, while men on higher doses sometimes do not, because the deciding factor is in your receptors rather than in your vial. Now the plan. First, do not stop or reduce your testosterone on your own, and I will explain why that is more serious than usual in a moment. Second, book a conversation with your prescriber and ask 3 specific questions. Could my dosing frequency be adjusted to flatten my levels rather than reducing my dose? Is my estradiol being managed appropriately or being over-suppressed? And could I have my ferritin checked, given how often blood is being removed? Third, consider the treatments that work on hair without touching your hormones at all. And topical minoxidil is the obvious one, because it improves blood supply to the follicle and is entirely independent of anything you are taking. Fourth, if after all of that, you and your prescriber decide a DHT blocker is right for you, go in understanding the trade-off, rather than discovering it. And 2 practical notes. First, if you obtained your testosterone through an online service with minimal follow-up, this is a good moment to get proper monitoring established, because these are questions that require someone actually looking at your blood work, rather than a form. Second, take a dated photograph of your crown and hairline now, because you will want an honest reference in 6 months. One thing, doctor, to viewer, and here is the reason stopping abruptly is particularly serious with this one. When you take testosterone from outside, your body reduces its own production in response. So if you stop suddenly, you are left with neither the treatment nor your natural production. And that gap can leave you feeling considerably worse than you did before you ever started, potentially for a prolonged period. That is not a small thing, and it is why any change belongs to your prescriber, and usually needs to be managed rather than simply halted. Testosterone therapy for diagnosed deficiency is legitimate medicine with real benefits for bone density, mood, energy, and muscle. Do not trade that away for hair on the strength of a video. And if your hair is falling out suddenly, in distinct patches, or alongside other symptoms, see a doctor, because that is a different problem. I am a doctor, but I am not your doctor. Now, one last honest word. The thing I would most like you to take from this is that you are probably never presented with the full picture, and that is worth correcting, rather than resenting. Testosterone therapy has moved rapidly from something managed carefully by endocrinologists to something available after a short online consultation, and the counseling that used to accompany it has thinned out along the way. The hair question is a good example, because it is entirely predictable, it is manageable in several ways, and almost none of those ways involve giving up your treatment. So the useful position is not regret, and it is certainly not stopping. It is going back and having the conversation you should have had at the start, with 3 specific questions and a photograph. Expect any change you make to take months to show, because you are still waiting on the hair cycle regardless of your hormones. With reduced shedding first, and an honest verdict at 6 to 12 months. So book that conversation, and come back and tell me in the comments what your ferritin turned out to be, and whether anyone had ever checked it. Type your age too. I read every single one. Take care of yourself. I will see you in the next one.